Well, the main challenge of pre-surgical evaluation is to find the area in the brain where the epilepsy originates. So the hypothesis is that we cut the seizure focus out and the epilepsy is gone. So the main challenge is, in the first instance, to identify really this point where the seizure onset, the pacemaker zone of the seizure is. And the second challenge, obviously, is to identify if we can remove this part of the brain without causing any neurological deficit. SISCOM is a method where we produce an ictal SPECT. SPECT is a investigation where we inject a radioactive tracer into a vein, and this tracer is marking in the brain the blood flow at the time when it's flushing through the brain for the first time. So we get a kind of snapshot of the perfusion, blood perfusion in the brain during the time shortly after injection. What we do now is we do that in the beginning of a seizure, and with that we will mark the perfusion state in the beginning of a seizure. And the hypothesis is that where a lot of neurons have to fire a lot, so the seizure onset zone, they need a lot of energy, and the energy comes to the blood, so there is a secondary increase in blood flow. And that's why we will have an area of hyperperfusion where the seizure onset is, and an area of hypoperfusion as a steal phenomenon in the areas around it, where they have less blood and distribution available because of the hyperperfusion. SISCOM itself is then again the technique where we have an additional interictal SPECT, so a SPECT outside of a seizure, where we have a normal perfusion, and we can then, with the computer, subtract the ictal from the interictal SPECT and co-register this with MRI, and this is SISCOM, so subtracting ictal SPECT co-registered with MRI. And that will give us the areas which have a specific statistical thresholds. Everything which is perfused more than 2 standard deviations above the mean will be shown, and that's then the SISCOM procedure. We are applying the SISCOM for quite some years, and we have started to apply the SISCOM in more than one seizure within the same patient. So we usually do apply the SISCOM for 1 week. So we have a tracer of SISCOM available every morning during a week. And if there is more than one seizure during the week and within the hours of this tracer being available, then we will inject more than one seizure. So we have collected over the time quite a few patients where we were able to have more than one SISCOM. And in previous studies, we have started to look if the SISCOM, if we have more than one SISCOM, if this is reproducible. And we have seen that in all of the 18 patients we had the first study, they have some areas where the SISCOM is showing hyperperfusion in both scans. What we have done now is that we're obviously interested if the area which is hyperperfused in both scans is more likely to indicate the seizure focus. So what we have done is all those who already went through epilepsy surgery and had more than 1 year follow-up, we combined this with the post-surgical scan to see if the hyperperfusion area of both SISCOMs is sitting within the resected area. So far, we have a preliminary outcome because we had 8 patients who actually have a post-surgical scan and have the outcome over 1 year. And of these 8, 6 have an excellent outcome with being absolutely seizure-free, and 2 have a outcome which is angle classification 3 or 4, so not worthwhile to be classified. And what we have seen is that the multiple SISCOM hyperperfusion zone in those patients who had a very good outcome was either within or in very close, or 1 centimeter relation to the surgical site, whereas those who had an outcome which was unfavored had a discordance with the multiple SISCOM hyperperfusion. This is early results, and it obviously needs many more patients to have a clear-cut view on that, but at least it's very promising that the increase of information within the SISCOM by having multiple SISCOMs is increasing the validity of the study. What we want to learn is actually if the overlapping areas within the multiple SISCOMs is giving us more information than only a single SISCOM. And we want to know if this gives us maybe a little bit more reassurance that we are actually finding the epileptic zone. SISCOM is applied usually in patients who have discordant other results or who have a negative MRI, so non-lesional. So these are the really difficult cases in the pre-surgical evaluation. And we often see SISCOMs which have more than one hyperperfusion zone, and then the question is which one is the one which needs to be addressed. So we hope that we increase the validity and the likelihood that we will find the epileptogenic zone.